Hello and good afternoon, everybody, and welcome to this webinar on new age management of the older age individual. Today, we are joined by specialist physiotherapist and director of Go Beyond Physiotherapy, Sam Jahan. And here at PhysiQuip, we supply specialist MSK technologies and provide several education resources. And one of our technologies we work with is the AxIT system, which consists of force plates and smart dynamometers to measure performance, prevention, or rehabilitation. And in today's session, we've asked Sam to cover how he's incorporated some of these tools into his clinical practice, specifically for the older population, which will be great to hear. So today, following the presentation, we will do a short Q&A covering some of the pre-submitted questions that we've received. If you are listening live, please feel free to submit any questions you do have on the Q&A tab, and we can answer some of those as well. So with that, I'm going to hand over to Sam for the presentation.
Thank you very much. Yeah, so the topic on new age management of the older individual, just to give you a little bit of background, we'll go through that in the first couple of slides as to kind of who we are and what we do. Yeah, if anyone does have questions as they go through, I think is there a question and answer thing there? I think, isn't there, Katie? Yeah. Okay. So just to make one little thing before we start. There's an R in Drahan, so I'm gonna make sure I spell my name right from the off there. You got it right in the emails, and then it was all fine there. So I'm
Apologies.
no, you're all right. Just if anyone's trying to find me on trying to find us on Instagram or anything, then yeah, it's that's that. All right, thanks. Okay, so just so we can define terms as we go through, so that we're all kind of singing from the same hymn sheet as to what we mean when we talk about certain topics. New age, just meaning that it's evidence-based and up to date. So this process should evolve over time. So anything that we talk about today was probably different to what we were doing 5 years ago. And then the same in 5 years' time, things will probably look a little bit different as well. Hopefully, they will look a bit different. Management, all I'm talking about when I talk about management is that it's a long-term planning or a long-term process, especially when it comes into therapy situations. We're often with patients for a relatively short period of time. And what we've managed to do in the clinic here is actually take a longer term approach, so that we've had people coming into our program for the bones of almost 6 years. When we talk about older age individuals, anybody over the age of 50, whilst there's no true age limit on our program, they're generally people who are peri or postmenopausal, at risk of losing significant muscle mass and potentially loss of bone mass, or they already have done. When we talk about the term intensity, especially when it relates to exercise, we're talking intensity as a percentage of someone's run repetition max. So if they can lift 10 kilos for 50 repetitions, it's probably not that intense. Or sometimes we'll talk about intensity in terms of their RPE, or their rate of perceived exertion out of 10, or RIR, which is repetitions in reserve, which just means, okay, I've lifted 20 kilos, I've got 3 repetitions left in the tank. So that allows us to dial up an appropriate level of intensity for that person. The difference, high intensity training versus high intensity interval training. So high intensity training just means that it's a high intensity of weight, i.e. RPE of 7, 8, 9 out of 10, whereas high intensity interval training would be more of your traditional kind of Tabata, your circuit training stuff, where it's push hard, do lots and lots of repetitions, and then have a short break and keep the intensity of your heart rate quite high. Physical strength. I have a real kind of sort of soapbox I'm going to stand on this, is that the physical strength is the body's ability to produce force against or to resist an external object or force. So I think it's really important to have that down as our definition, because then it tells us that actually the person who can produce more force or move more weight is stronger, to move away from this idea that a lot of low-level exercises are actually improving older adults' strength when they're probably not doing that. Rate of force development, which we're going to come to later on, is important for us to be keeping an eye on. There's an emerging body of evidence where rate of force development is the ability person to display force quickly. So that becomes really handy with the AxIT system, where we can actually measure that, which is effectively going to be the steepness of the curve that we measure from people going from producing no force to producing their maximum force. That's pretty much indistinguishable a lot of the time from power, but power is just a measure of watts, whereas rate of force development is actually the measurement of the speed. Osteopenia and osteoporosis. So we're talking about T-scores here when someone has their bone density scan. So their bone density might be sitting 1.5 standard deviations or 2.5 standard deviations below the normal. And sarcopenia is a syndrome characterized by progressive and generalized loss of skeletal muscle mass and strength. And that's an important distinction when we're talking about older adults as well, is that they can have some skeletal muscle mass, but they may have a large amount of strength loss, and vice versa. They could have actually quite low levels of skeletal muscle mass overall, but be actually quite good at using a lot of that strength. And because when we're looking at somebody, we can't just assume because they've got some skeletal muscle mass that they're actually that strong. And this has large impacts into physical disability, quality of life, and then unfortunately increased risk of early mortality. So just to go through a little bit of what we're going to cover now. So who I am and who we are at the clinic, why do we focus on older age strength, what we do about it, and how you can do the same. So the plan from us normally is that we are trying to engage with everyone and give everyone their own time. So we offer everybody initially 45 minutes of sessions and 45-minute follow-up sessions, so that we can actually spend the time doing strength sessions, doing fitness sessions with them. We're trying to empower every single person that comes in the door to give them the tools themselves, that even if they're not strength training with us, they're strength training with somebody else. We're looking to enhance and improve their health. So every time that a person comes in as a first point of contact, we're trying to address their problem, but we're also taking that step back and looking for that overarching view of their health, which especially for the older adult is extremely important, which we'll come to later when we look at our seesaw of things that we can control versus things that we can't. And then we're looking for them to explore and find something new. So this is where the social connection is extremely important, and often lacking in older adults, especially kind of around since COVID. We've seen a lot of social isolation, people losing contact with friends or the groups that they would have been involved in and not getting back to those. So why did we focus on the older age adult? Because the gym that I work out of, or my clinic is based in, is AxIT, and their goal of improving the health and fitness of 10,000 people in Killarney. And then Go Beyond Physio's goal is of developing a program enhancing the prescription of strength training in older adults who are generally severely undertrained. So that combination together brought about AxIT Masters as the program. The why behind this as well, if we look at like population demographics for Ireland, I am based out of Ireland, not an Irish accent. I am Welsh, obviously. If it hasn't lost too much of my too much of my lilt. We've got here a huge potential time bomb in population demographics kicking up. Whereas if we look at 2023, we have, especially in the 80 plus category, we've got at the moment nearly 200,000, and then potentially over 500,000 in the population of 80 or over. So it's a population that's going to need huge amounts of input now, ideally 10 years ago, ideally not in 10 years' time. And within those demographics, only 17% of our adults are actually meeting any of the physical activity guidelines set down by the World Health Organization. In my opinion, these guidelines aren't actually enough anyway. So even though the guidelines are low as some low-hanging fruit to hit, we're not even hitting those. Especially when it comes to the 2 sessions a week of exercise around balance and strength training. If you look at some of the recommendations that they incorporate, if I see them talk about tins of beans anymore, I'm going to lose my mind. It's like tins of beans ain't heavy enough, which we'll see how many tins of beans what some of my clients are lifting later on. Social isolation heavily linked to increased wish to die, which is a measure of potential suicide attempts in the older adults as well, which is increasing. And in general, weaker legs is going to increase your social isolation. Weaker legs leads to increased social isolation. There's a huge correlation between those. And as I mentioned, yep, definitely since COVID-19, that pandemic has impacted a large amount of people's group activity. And even if we can't have huge impact on people's health early on, we can have an impact on something. So whether it's to do with them getting them out walking again, getting them meeting up with friends, it doesn't have to be that we have to get them in the gym at this point. It might not be the right time for them in their life. So group fitness is generally a little bit more financially affordable as well. So that's where the long-term management of these patients and clients come in, is that we can keep them in-house so that A, they're not in with the GPs, B, they're not in the hospital. So especially when we were setting up the program, we had a look at what these barriers to resistance training were going to be. And generally they're listed here. So poor health, injury risk, pain, tired, fatigued. People don't feel like they're actually quite up to it. They have a low sense of what they can physically achieve currently or what they could potentially achieve in the future. Psychological barriers, willpower, their attitude towards, again, what they can do or what they could do, their own literacy about health, about like what it means to strength training, what the end outcome is going to look like. Too old, it's still, even with all of the popularity of things on social media and news articles and radio about pushing this, there's still an idea that all people can somehow, get injured. They can somehow put on a huge amount of muscle mass, and that definitely in Ireland seems to be a little bit more that if I lift too heavy, I might give myself a heart attack or I might give myself a stroke. This seems to be like I don't know, it's some sort of geographical thing where it was published around the time, but yeah, it seems to be quite more common than you'd think. Social barriers, so family, so that especially with people coming to go back to work post COVID now, mums and dads working, grandparents are now having to get involved more in childcare. So there's obligations and responsibilities from that, which can take away from time to take care of their own health. And environmental factors, which is generally the most difficult one to address wherever you are. You've got to deal with what you've got. So facilities, geography of where they are, age appropriate programs was the big thing as well. It's like actually having programs that are appropriately intense for that population, but also then not under prescribed, which is almost as bad as being overprescribed. And just that even with strength training, we can generally predict how people are going to be when they're actually older as well. So we're looking at this study where it was over 1 million Swedish male adolescents, and they took their knee extension strength and their hand grip strength, and it was a huge predictor for early death or potential risk of cancer, development of cardiovascular disease, increased risk of suicide. So any patient that comes through, we should have in mind that this person could end up being somebody who's going to have an increased risk of comorbidities, poor cognitive health. And we should be at least addressing a question where, are you doing any form of resistance training? Are you doing any form of exercise? What are you doing at the moment? As really, this is about an ounce of prevention being a pound of cure. In that when they do get older, that we don't need excessive amounts of programs like the ones that we run here, with they're actually independently strength training themselves. So just to give you an idea of what like a program or part of the program looks like here. This is Maria.
My name is Maria O'Connor. I've been coming to AxIT for 2 years and a couple of months. I came because I have a bone problem, which has improved no end since I came here. I had lost all my confidence and it is all back. I don't care what I do now, and it's all down to Sam. So I love it, and everybody loves it. And we work at our own pace. Thank you.
So you'll see a little bit more of Maria later. She is like she's a proper pocket rocket. She's about, I think she's just over 5 foot and probably about 45 kg soaking wet. But she's unbelievable what she's accomplished in her time with us, which is probably about 3 and a bit years now, actually. So what's evident from this video? Stronger legs. She was squatting, well, she's up now to squatting 53 kilos for 5 reps. Stronger arms. She's knocking out pull-ups 6, 7, 8 reps with this little bit of a band assistance. Her mindset's been the biggest change. She'll tell you herself that she had a huge shock when it came to her bone density diagnosis, and having support from someone who was going to like push her a little bit, but also support from the group that were in there as well. And that's often a big problem or big missed opportunity with group programs, is actually, you know, getting the social connection between people, and they, when they are having a tough day, it's like, oh, I can need to go in and I've got somebody there I can chat to, and we can work our way through a session. What's not evident is her bone density has had a massive change. So she's was minus 3.7, and now she's up beyond she's into about minus 2.9 in her spine. So she's actually reversing her osteoporosis without the need. She's supplemented with calcium and vitamin D, but not any other more aggressive medications like anti-resorbitors, bisphosphonates, and things. And what's changed is her mindset is that she managed to travel to Australia at the beginning of the year to meet her son for the first time that she'd ever traveled to Australia, and that she attributes to feeling confident that she could go and do that and travel and carry her bags and stuff. So when it comes to the program, like the idea behind muscle mass retention or improvement and bone density retention improvement is that we want to avoid the development of a phenomenon called osteosarcopenia. So when it comes to osteosarcopenia, we've got osteoporosis being heavily publicized in the last 3-4 years, especially over in Ireland with GPs that's doing a lot more screening. The sarcopenia element is not really talked about too much, but it is very much a cycle between the two phenomena. So we've got a huge variety of potential factors that can affect people's loss of muscle mass and strength, which is important to remember in that sarcopenia diagnosis. And then from an osteopenia or an osteoporosis diagnosis, it's the density of this bone mass. So we get loss of physical activity, potentially low vitamin D and calcium, which in sort of this end of Europe, we've got generally low exposure to sunlight, and our vitamin D levels are generally quite low. Long-term corticosteroid use, which in the increased number of comorbidities that we're seeing older people have now, people are generally living longer, so they're more likely to accumulate these as well. Things like COPD, rheumatoid arthritis. Long-term corticosteroid use has enormous impacts on people's anabolic process to build muscle, and actually increases the catabolic process, which is actually to then lose muscle mass and lose bone density. Aging, probably not a lot we can do about that. That's going to happen. That's probably a non-controllable factor. But things along the lines of inflammation and the potential low protein intake, fat infiltration, so excess adipose tissue, visceral fat, and like we've already mentioned about comorbidities. So we see a cycle where we're losing muscle mass, we're losing muscular strength. That's reducing the tension and load that naturally occurs through the bones. So the body's going, well, if I don't need all of this bone, well, I'll get rid of it. And I know your body's very good at maintaining as little as it needs from an energy balance standpoint. So that's a vicious cycle that ends up being a risk of falls increased due to lack of muscle strength. And then obviously if you've got low bone density, the risk of fractures increases as well. So early on, the earlier you can get this, the better. Not developing into an osteosarcopenic position. So if we think about all of those potential factors on a seesaw, where we've got potentially on the positive side and on the negative side, so they're maybe on corticosteroids, maybe, you know, they're in post-menopausal, they've got comorbidities, you know, maybe COPD or rheumatoid arthritis, low calcium levels, or they've got a poor dietary intake from calcium. Maybe they only ever drunk skim milk. Vitamin D levels low, just inherently, or just due to again poor diet from greens. Low physical activity, low protein intake, fat, increased body fat, inflammation. So like even if somebody's coming in, we're not going to look to get rid of all of these things. That's an impossible task in the first session. but at least moving some of what we can control to offset. Like, we can't offset aging. They may never come off corticosteroids. Their visceral fat levels and their cholesterol may never change. They may be a genetic predisposition to that. Their hormonal balance and comorbidities, again, whether you're going to change those or not is it's very difficult, but you can control what you can control. And they will have huge amounts of impact on someone's bone density, someone's muscle mass, and then therefore their general health and outlook. So, like, what tends to happen, unfortunately, is like the typical care for older adults is like, Mary goes into the GP with a back pain. It's like, take care there, Mary, back sore, rest and put your feet up. Unfortunately, we've got a lot of data where we're seeing people who are in bed rest in hospitals. They're given they're on a certain amount of protein. We'll discuss that's the recommended daily allowance of protein. We're going to discuss why that isn't enough anyway later. But that's the recommended daily allowance that they should be hitting. And 10 days of bed rest lost between 3 and almost 10% of their lower body muscle mass. And then on top of that, they lost 15%, potentially maybe even higher, of their knee extension strength, which is extremely important in terms of their general functional independence. And then what they'll end up doing is these type of people, or these type of patients, will leave hospital, be in a worse state than when they went in, increased risk of falling, they're back in a month, and then there's the cycle turn on. So getting these people early on and maintaining resistance training throughout life is to prevent this. Now, 10 days of bed rest in the hospital, yeah, okay, that we're probably not sending Mary for 10 days of bed rest at home. But if we take Mary's case here, where it's like back pain, could be having back pain for 6 weeks, could be having back pain for 12 weeks. She's not completely rested and idle, but she's a lot less active than what she was before. So I think these numbers are pretty appropriate for potential loss, especially in a community setting and not in an inpatient setting. So rate of force development, to move on from strength, is that ability for us to produce force quickly, and that's generally lost with age. Big issue with rate of force development in injuries, post-surgeries, things like your ACLs. Really important to restore rate of force development in that. Pain's quite inhibitive of that, muscle mass and muscular strength as well, due to generally we preferentially lose type 2 muscle fibers as we age. Why we preferentially lose them, I think it's underappreciated, the use it, lose it kind of an analogy here, where if we're not trying to move heavy stuff, we're not trying to move things fast, your body's very clever. Well, I don't need this. And it naturally gets rid of it quicker than it should do. More peak force, so that's the maximum force that you can actually achieve, will not necessarily yield a higher rate of force development. So it's really important to make sure that, yep, we're going to move heavy stuff. We're going to get ourselves, strong, lifting weights that, okay, I can lift it 5 times, but maybe not 7 times. But we need to also be training things to move fast, which is really important and correlates quite well with gait speed. So increased rate of force development has been shown to be associated with a faster walking speed. Also better reactive balance. So again, we're looking at the potential for falls to be reduced significantly, able to move our feet much quicker, stop ourselves falling. So just using the AxIT system, so just to give you an idea of what we're using here and why we're using it. The image on the left for knee extension, we can see that we've got a very steep curve on the purple line. So this is just showing that this person can go from there's no force at all to hitting their max force very, 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 very quickly. What we've got on the right here is this is actually an older lady with some lateral hip pain. And so her hip abduction score is significantly reduced in terms of strength anyway, whilst she is better than what she was. But you can see with the curves here, it's a much less aggressive climb. So she's able to put in, she's able to put in 7.5, 8 kilos of force, but it's very slowly brought on in the grand scheme of things. So we do want that rate of force development to sort of increase significantly. So as our exercise prescription changes, She might get, high amounts of force, but can she do it fast? And that's where your exercise prescription should change. Protein intake. Especially we address this quite a lot within the first couple of sessions as someone will come in. Recommended daily intake is 0.8 grams per kilogram of body weight. Generally, this is not good enough. It's generally okay if you want to like stay as you are, but for older adults, they generally will have a reduced anabolic response when we start talking about what they'll respond to with protein and what they respond to with exercise. So especially with chronic health conditions, aging, long-term corticosteroid use, reduced levels of physical activity. So the recommended daily intake for young men and women when we're building muscle during weight training is minimum 1.6 grams per kilo, even as high as 2.5 in some. We aim for this. And what we do have is some good literature to say that, actually when you actually up it to that, regardless of whether they're doing high amounts of resistance training, it can have significant impacts on maintaining their muscle mass, just adjusting protein intake. So again, if we think back to what the seesaw, maybe we can't get them physically active at the moment. Maybe they post-surgery, they're still getting over certain things. What we can do is bang for buck early on. Okay, we're going to do little bits of exercise, going to get you moving. Let's talk about your protein intake, because this is going to have a huge impact on you in the long run, and setting those standards and those routines and that schedule to get into the habit of, okay, you need to be thinking about protein intake for a little bit more at breakfast time and spreading that throughout the day. We incorporate that a lot within the program, and that needs to be really, even physiotherapists, we need to be much more upfront about asking questions about this. Retention is a huge issue with long-term strength plans. Generally, 50% of over 60s will drop out of group fitness before 6 months. There's a lot of potential reasons why. Again, if we look back to what the barriers to exercise and resistance training were in the previous slides, there's all sorts of reasons why people drop out. We have a retention rate here of over 85% for anybody who's attending more than a year. So we can get them up to a year. We've got them for life. So what's happened here is that we've engaged them social connection wise. We've got external events, getting out long walks, involved with walking clubs, Christmas parties, holidays, all that kind of stuff that they get involved with people who they haven't met up for in years. The feedback that we get from the program with us is that we have a high confidence in that, the fact that it's a medicalized assessment, and in that they're coming in and they're not just dropped into a gym environment, and that somebody maybe hasn't got a lot of experience dealing with the older adults, and they're going to be able to exercise and load them appropriately. The prescription of weight training. So rather than saying that, okay, you can, there's a weight on there, Mary, have at it. We prescribe a specific weight for them to aim for in that session, and that changes based on the week, based on the month that we're loading them. We get very good feedback about that, because then they know that they're doing a weight that's appropriate for them and it's safe, they're able to do, but it's going to challenge them and it's going to get the outcome that they want. Honesty from the initial session. The biggest thing with this is that definitely Irish mammies can smell a lot of nonsense a mile off, right? They've been through countless doctors and consultants, and they've got a really good nose for knowing when someone's feeding them a load of nonsense. So they do appreciate here that we say, right, this is what's going to happen. It's a long process. We'll start here. I'm not going to promise you anything, but if you keep this and we do the minimum amount that you need to do, you're going to see changes. Getting a good referral pathway from GPs and consultants. Definitely the kind of 65, 70 plus do have a lot of faith in their general practitioners. And so when they get an idea of that the GP is saying it, they've maybe got word of mouth from somebody else, maybe they can see a consultant as well. That's being able to build that up in a strength program for older adults is extremely important. Variety, that's a huge part of this. Now, variety for variety's sake, you don't then get your adaptations that you're looking for in strength training. But what we do, as you'll see later when we come to the structure of the classes that we do, we keep a variety quite high. Aiming at long-term health, not pain-centric. So yeah, generally aiming physios, we see everybody in pain. Initially, that's their problem, but we taking that long-term health look again, looking at that seesaw. It's like, okay, the next 6 weeks, we're going to have a bit of pain problems. What can we address in that time to really, not that you'll speed up the recovery, but make sure, A, that you're better leaving, you're in a better position in your long-term health leaving than you are when you came in, despite if your pain's better or not. So again, just an idea of what a class kind of tends to look like here. So this is Maria there. So you see there's a fair amount of weight for somebody of her size. There's a fair amount of struggle on the way up to that. Maria also. "24 inches, if anybody wants to drink there." Yeah, so she's I'm running out of boxes for Maria at the moment. So yeah, she's I mean, she's, like I said, she's about 5'2", but she's got like a 24-inch box jump there as well. So she's pretty she's a big outlier in that sense, but it just shows what can be done. We've also got our deadlift, which is generally done once a week. So you can see the kind of general size of the class in there as well. Generally, everybody does the same. Everyone will run the same class. This is where the prescription comes in. That's really important, that we prescribe specific weights for specific people, in that it's then at the appropriate intensity for them. So what is the program? So we run an individual assessment. Everybody comes in full, which we'll talk about in a second. We then go through 4 one-to-one sessions to teach them how to move, how to use the equipment, what's expected of them when they come in. And then they attend 2 sessions a week. That's non-negotiable. And their program, we program from my side, we're in 6 to 12 week blocks, but it runs indefinitely through the year. So this is, I think, where a lot of group fitness stuff tends to lose people, is that they say a 6-week osteoporosis plan, or an 8-week summer plan for osteoarthritis, and these kinds of things. And then they fall off and they lose them and they just run again, or they try and run it again, but there's no actual progression. So that's why we kind of it runs indefinitely. Heavy compound movements, so deadlifting and squatting, generally getting up towards 85% of what they can lift. So, moving a weight that they've got about 1, maybe 2 repetitions left in the tank. And the goal for us is to move heavy and move fast and move well. So this video here is of Tim. Bit of background for Tim. He is now 87. He had pretty severe lumbar fractures due to low bone density. Couldn't come upstairs when he came in. And he's been coming up the last couple of years. And yeah, so there's no limit on age. Like this idea, I'm too old, I've never done weight training in my life, I'm never going to be like that again. It's a load of nonsense, basically. It's like if your clients are making those kind of statements that I don't want, it needs to be challenged. They're leaving a lot on the table. So Tim there, yeah, he's lifting 50 kilos now. He never lifted he was never in a gym in his life. But yeah, so he's a very good example, and generally the best dressed example of what comes in. He is, I think his daughters did ask him that he was going to wear a tuxedo the next time, so I'm waiting on that one. Okay, so what does the individualized individual personalized assessment involve? So full medical history, we take blood pressure, we take an in-body scan, so that gives us an idea of what the level of skeletal muscle mass and visceral body fat levels are to start, and then we perform an AxIT assessment. So we'll go through that in a minute. The in-body scan, they're generally pretty good if you can make sure the time of day is consistent, so that they're generally the same hydration levels and things as well. They're very good at comparing one person's results to their own results. Comparing people to people is a little bit sketchy, but in general, that the in-body scan has been pretty good for us to monitor people's skeletal muscle mass levels, as we've measured them every 3 to 6 months since they've come in. A functional physical exam. So we incorporate grip strength into this. We incorporate 30-second sit to stand. We use the 30-second sit to stand initially. It helps us identify whether they're good enough to go into the program early on. But we know, and same with this short performance physical battery outcome measure. Those can be used in your lower level clients initially, but what we tend to try and think about here is that actually I want to get this person so strong and so good that those tests actually don't tell me anything about them. They're too good for the tests. We also incorporate a lot of nutritional information. We have an in-house nutritionist, which we work a lot heavily with from a body composition side of things, so losing visceral fat, and also to idealize and sort of set their protein targets. So if they can't do that with me, then and they need a little bit more accountability and more catch-up time once every week, once every fortnight, then we set them up with the nutritionist who works in the gym with us. So our AxIT assessment with this client, so when they come in, we will do some form of squat, some form of forward lunge, a knee extension at 90 degrees, and a side-lying hip abduction testing. We are experimenting a little bit the mid thigh pull at the moment, but just in terms of getting people to do it consistently, it's tough with we seem to be getting a lot of people through with sort of rheumatoid arthritis recently, and like the grip side of things is sort of affecting their ability to do mid thigh pull. So I'm not entirely sure how much we're getting out of that right now, but we're going to keep an eye on it and use it as optional, and maybe use it as a for a specific client that we will. So why these tests? So squat. So we're looking for assessment of squat depth, their pattern of movement. Are they avoiding one side versus the other? Are they kind of heavily loading into their hips? Are they not really bending their knees? And a squat is a very good measure of functional independence. We've done this where we've got people to squat to a chair, and if you can't do it as a freestanding squat, like our superstar Maria does there. Forward lunge. Again, what we're looking for is an assessment of asymmetries. It's a really good screen for knee osteoarthritis as well, and then the ability of confidence to assess their ability to get on and off the floor, which we'll come to right at the very end as to why that's important. Peak quad strength. So we take a isolated quadricep measure because the squat and the lunge will not tell you how strong someone's quads are. They'll tell you how strong they are in the movement, but they will not tell you in isolation how good their quads are. Toes up the shin, chest up, looking forwards. 3, 2, 1, push, 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 harder, 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 harder. Keep going, keep going, keep going, keep going, keep going, and relax. And then same again, toes up. 3, 2, 1, push, 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 go, 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 keep going, keep going. 3, 2, 1. I do sound a little bit like a midwife when I'm saying push, 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 push a lot as well. So I do get that a lot. So that it's important from that isolated quads measure to take place purely because of how that's in the research associated with a lot of these measures of functional independence and falls. So we're monitoring that quite closely with a lot of these at the moment. Maria's a great example. She probably aces a lot of these tests anyway. But even if you can't get someone to squat, you can't get someone to lunge, you can get someone to do a peak quads test. It's there's no real limitations on that besides maybe pain and osteoarthritis if you're having a large flare up, but you're going to need to get some marker with that anyway. Cool. Hip abduction. We take this not from necessarily a fall side of things, but due to the link with greater trochanteric pain syndromes and OA knee, that we get a good effect from training hip abduction and not needing for any further interventions from surgery as well. So we take a measure here. And the population that we tend to see in the osteoporotic side of things, osteopenic side of things, tend to be more women. So they're more likely to be experiencing some issues with their gluteal tendons and greater trochanteric pain syndromes. Grip strength we take as it has a massive correlation to health and hospital readmission and mortality risk. So I like this study. I think this is the Germans. Because what they do for this is they actually stratify and they classify people by their height as well. So you've got age and height, and then it's an appropriate grip measure for themselves. So we use this one. And it also then gives us a threshold of like what the average would be, or what the average grip strength would be for that age group at that height. And then it also gives you a threshold where like, okay, they're actually below they're one standard deviation below where they should be, which has an 86% increase in early mortality within the 8 years that they do the test. So if they're below that threshold on that score, it's a concern, and they need to be. They really need to think about actually kind of incorporating some elements of resistance training. So even if somebody's in and they're in there for their rotator cuff, they're in there for their back pain, you can do this quickly and say like, oh, we're just going to take your grip measure as a standard part of our assessment. And then, once you start getting that person better and feeling like they are pain-free, it's like, okay, this is now the time to really be doing this, because you're below this threshold and the risks are there, and we need to be getting you in. 30 seconds sit to stand. I like it initially. It's very quick and easy, especially if you're community based, as well as like no real need for equipment and things. Generally, what you tend to find, though, is once you can get over 13, they're probably just too good for the test. If they're knocking out 15, 16 of them, it's like, okay, is it actually a test that's telling me anything? Short physical performance battery protocol is, again, standing, gait speed, balance, good at identifying risk populations for falls and low muscle mass. This is actually free. You get a PDF. I think the link is there. You can also get it on an app, I think, as well, which I think is free as well. Really quick and easy to administer as well, and very good evidence behind showing improvements in that and reducing a person's risk for falls. If I was in the community, I would have a grip strength dynamometer. I would use the SPPB, and I would get an adjustable kettlebell. Especially since COVID, these have come down in price a huge amount. Don't buy them in COVID like I did when they were about 300-400 euros. They're about 100 euros now, or maybe just a little bit over. If you were to buy, so if we take the one on I think when I looked at this morning, the one on the far left there, I think you've got like 6 potentials, like 3, 6, 9, 12, 15, 18 kilos of potential weight. If you were to buy all of those separately, not only would it take up the whole space in your clinic or the whole boot of your car if you're going out on home visits, but it would cost you about 3 times the price. So they're extremely handy, and now actually very cheap and affordable as well. The price of of an assessment and over here it would be like 120 euros would be the price of an assessment and treatment session. So you've already made your money back there. If you don't have access to heavy equipment, in Ireland, there's over 2,200 GA clubs. Every one of them's got some access to some weights in the gym. In the UK, is almost 5,000 gyms. From a therapist side, if you're working in private practice clinically, and you don't have access to, or even have room to be able to do larger amounts of strength training with people, it's like getting involved with a gym and setting up business cases where you're able to go, I've got 120 older age clients that come into me. Half of these could do with going in the gym. We can and we know from the demographic side of things that like that older population is only getting larger and larger. Like gyms have got a financial case here to be able to get involved with a physiotherapist locally to be able to set these things up, and make it financially viable. So from our side of things, a class typically looks like we do a squat or a deadlift on one day, generally somewhere between 1 or 5 reps in reserve. That's generally where the research tells us that strength improvements are generally made. Generally, if it's a 5 out of 10 effort or lower, you're going to struggle to see long-term improvements in someone's strength. We need to be kind of coming a little bit higher than that. Reason we do squat or deadlift, generally we split them up just so that we don't get an effect where we've done a heavy squat and then they can't lift as heavy in the deadlift. So we need that heavy stimulus, so we separate those two out. On our secondary pieces, we'll then do an upper body push-up-pull. So that could be anything from a push-up to a floor press to a dumbbell press overhead to landmine presses with bars. I purposely didn't put all of the options down here just because like if anybody wants to chat to me about this later, then please, like, they can obviously contact me through emails and things like that as well. But it's just for like an idea of structure. Then we include some lower body stuff. So these are things like lunges. If we put our lunges, our step ups, our box squats, biasing one leg, single leg RDLs, and then potentially, depending on the time, we've got a third piece that goes in here. Invariably, it's two. And then our metabolic conditioning piece. This is where the variety comes in. So we've got lots of potential stuff where we work on longer 12, 14, 15-minute aerobic pieces, shorter pieces where we're going minute on, minute off for anaerobic thresholds, or even things then max bout efforts where it's 10 seconds of work and 50 seconds of rest, which do actually have some nice data on like how that improves people's or older adults' power, and their rate of force development is like telling them to go absolutely ham for 10 seconds on a echo bike or assault bike and take a full 50 seconds of rest. You know, these types of things, you know, they're going to be limited a little bit by initially just their strength, but you'll be surprised at how good and how much power, how much watts they can generate eventually on a piece of equipment like that. Bodybuilding, pump sets, balance exercises, floor transfers, all sorts of things. I think things that are going to help keep volume quite high. So this is where our repetitions in the early strength stuff is quite low. So we've got, like I said, you may do 3 rounds of 4 of our deadlift and then 3 rounds of 6 of our lunges. So this is where we can then make up for like lots of higher volume, pushing them to fatigue and really stimulating a good kind of muscular hypertrophy response there as well. So just an example, last week's session, deadlift, we did 3 sets of 3 plus 2 plus 1. So that plus means or meant that it was like a little myo set. So we could do like a 3, 10, 15 seconds break, do a 2, 10, 15 seconds break, and then do a 1. That's about as complicated as it ever gets. It's normally not that complicated. We're coming to the end of a cycle, so we've changed it up a little bit. With that, we've got a full 2 minutes, maybe even sometimes 3 minutes of break. Especially if you're really doing strength training in that inverted commas, you are going to really struggle to get back within a minute and do it well. There is a little bit of evidence in the older adults that actually, you know, 60 seconds is probably enough. Anecdotally within the session, I don't think it's enough, especially with when some of them are getting their deadlift over their own body weight, 2, maybe even 3 minutes to get the actual stimulus that we want and not feel like they're dropping the weight too soon. Yes, so that normally takes up to about the first 20-25 minutes of the class to build up to that. And then we've got goblet cyclist squat, so a heels elevated squat, 4x8, and then a B stance RDL. So that's just 1 foot back and then loading and hinging on the one leg. And then our conditioning piece. So this is where the CrossFit style of metabolic conditioning pieces can be really handy for incorporating a lot of volume and keeping things kind of fresh and having some variety in the program. So it was a lower body piece where we went 21 reps of everything, 21 reps of forward alternating lunges, 21 down ups, which is effectively a burpee without going to the floor. So you're standing, you go into a plank, you stand up again, and then alternating dumbbell snatches. So snatch dumbbell from the floor, finishing up overhead. So everyone had to do 21 of each and then go back and do 15 of each and then go back and do 9 of each. So overall, we built up that over that's a 10-week cycle. So we built up to effectively in that conditioning piece, you've got like over almost like 135 reps of like hinging type hip dominant movements. So it really shows that like just have a look at the like if you've got an older adult coming in, just see are you building them up to be able to do 135 reps of hinging? Like they can take that. If you build it up, they've got strength and capability. You might have to change a lot of things. You might even, in that example, we started out 10 weeks ago, we didn't do down ups, we just did press ups instead. So there was no hinging, but it was some sort of stimulus. And then we brought that in gradually over time. But they can do that many reps. It's not beyond them. This is my soapbox. This is one of my soapboxes, I should say, I'm going to stand on. We include floor transfers, or effectively just getting on and off the floor in every single class. Falling and fear of falling is an enormous problem, whether it's due to previous falls anxiety, their mate has fallen and fractured her hip recently and she's stuck in hospital still. Like, ask your clients, how are you getting on and off the floor? And watch what they say, watch what they look like. Get an idea of how they might not be confident doing that. Learning how to get on the floor is a skill, and generally it's because they don't practice it. It's when was the last time you got up and off the floor? Especially even the examples that we get from the class is I can get down on the floor to play my grandkids again. But that's an element of building strength, confidence in the task. The warm-up we use as an entry point to getting my clients on the floor. So what we'll say is you're going to end up on the floor at some point. I don't want you to fall, but you're probably going to end up on the floor at some point, for some reason. I need you to be able to get on and off the floor. So that's why we do it. So we can take examples, where our warm-up might be initially maybe some pulls on the rings or pulling of bands. And then we might get to the next piece of the warm-up might then be something to do with warming up shoulders, maybe in a lateral raise. Okay, I don't need to do that in standing. I can do that in kneeling. So we go from there, we progress down to kneeling. That's our next piece. Okay, next we want to warm up hips. Okay, on your back, on the floor, we're going to do hip bridges or single leg hip bridges. Get them on their front, roll onto their front. We're then going to do some shoulder raises when they're on their front, warm up the back of the shoulders. So we're warming them up for what's happening in the class. But we've got in mind you're kind of sneaking in floor transfers. We're sneaking in the idea that they're getting down to the floor and getting back up. So we're not working on it as such, but they're getting exposed to it every single day so that when it does happen, they're like, oh, I can do this. I've been here before. So when we are doing the warm-up, it's do I need to be standing to do this warm-up? So that's if you're going to take anything away from today in terms of adding floor transfers into your older persons program, or starting a program, you think, do I need to do this standing up? If not, can you progress into the floor and back up again through 5 to 8 minutes of a warm-up that you've already then accomplished the floor transfer element of what's so important to a lot of these ladies and gentlemen. Or could it be upside down? So we've only recently started bringing in handstands again, and handstands again. When he started bringing in handstands at all. So Maria, I remember Maria's 69, never done a handstand in her life. Again, incredibly impressive individual. We've also got 2 more who've started doing that as well, out of a cohort of about 50. So a summary of the program really, and the use of the AxIT system has made a big help with this as well, is that we meet them where they're at. We know what they can do to start. We know how much force they can produce, so that I know then if I can get Mary to kick out, 10 kilos on a left leg and 9 kilos on a right leg. Okay, if I give her a 5 kilogram dumbbell, it's to squat with. We're already kind of showing that, okay, this is well below what you're capable of, but we're just going to get you started. We don't get everyone. Some people, it's not the right time, life-wise, logistically, they're not able to commit. Okay, I can't help everybody yet. But even us getting that contact face-to-face and at least being a point of introduction to strength training or changing those lifestyle factors that we talked about on the seesaw earlier, that's where you're going to make huge differences. There's heavyweight training. We train for physical strength, and we move those lighter weights faster for power. Weight force development will improve with strong muscular contractions and the intent to train hard. So even if you've got that kettlebell, you get to the point where you're lifting 18 kilos with somebody at home, and you've maxed out with that adjustable kettlebell. Okay, let's get you moving that thing faster. So then the intent comes in, and that's gonna, okay, you're out of weight. That's fine. We'll move it faster. That's progression as well. High peak forces, creating high loads in the skeleton to stimulate bone density. That seems to be where the magic is happening at the moment. In that the higher peak force you can create, the more likely the skeleton is going to adapt. So where this is again where high reps, low weight. We're trying to move away from that a lot. And we're trying to incorporate new movements or positions they haven't been before. So that's where the floor transfers come in, is that things that they won't have done or avoided, even lunging with total knee replacements, something along those lines. There's like new positions or movements that they haven't been in or they've avoided and they've been fearful of. Don't let the fear stop them. And this is a recent publication that's come out from somebody who has probably got a lot of skin in the game from older adults as well, which I suggest that you read if you are looking to start an older person's strength program. Best thing to do, because I don't think it's freely available at the moment, but if you contact just dustinjones.dpt on Instagram and send him a message, he sent it to me for free. So yeah, I think he'd be pretty happy to send that out. And okay, I waffled on for the bones of 40 minutes or so there. Have any questions, please?
Yeah, thank you so much, Sam. That was really good. Very interesting. And I feel like I need to step up my training now, watching some of those videos.
Yeah, they definitely motivate me as well. It's like, right, I coach them. It's like, right, I need to get my backside in the gym myself. Yeah. Like, can't be letting them. Not one of them hasn't passed me on a squat or a deadlift yet, but like,
but creeping up, yeah.
It's getting a little bit too close for comfort, to be honest. Yeah. Yeah.
Yeah, it was those box jumps for me. I think, yeah, I've got to be getting on those. I think
she's a phenomenal athlete though. Like the majority of the guys in the class are probably doing 9-inch, 12 inches, 15 inches. It's still high, but
yeah.
and again, because she's so small, it's so like she just disappears into the sky. Yeah.
Amazing. No, really, really interested, and so good to see the work really that you put into that. So yeah, excellent. So we've got a bit of time to go through just a couple of the questions, if that's all right.
Yeah, fire away.
Again, if there's anybody live who wants to pop a question in the Q&A, then please feel free. So one of the questions we had initially through the pre-submitted section was, why is rate of force development important for older adults? And I know you covered that pretty well, really. You mentioned about the correlation between the gait speed, the balance through movement, and as well. So what would you say is important with regards to sort of continually monitoring the rate of force development and reassessing throughout the program?
Yeah, so I suppose with any outcome measure, if you're doing it initially and then not really using it afterwards, you're not really knowing what you're implementing is doing anything. Like generally within rate of force development, you might expect some changes. Even after like even after a couple of weeks, significantly. The difficulty with the rate of force development is that it can be affected quite a lot on the day by you've had a really bad night's sleep or they're wildly stressed. So obviously it's a little bit more like variable depending on on how they are on the day. If they've been a bit run down, you lose that. But that just shows it can go quickly, but it can come back quickly as well. But like I said, measuring it, same with peak force, very measuring. You have no idea if you're actually making this person stronger. And that's where, like, in the research, it's like, yeah, you need to show, yeah, we've done X protocol, it's done X amount to improve this person's strength. You can't measure it with your hands. You can't, even things where it's like that 30-second sit to stand test. If they're functionally poor, you'll get the right people in, like, failing that test and then being better at it. But if somebody's like, I can knock out 13 of these, they're probably too good for the test, and actually they benefit more from a more in-depth assessment anyway. And it's like, yeah, actually you're able to compensate a bit by like using your hips a lot, and your quad strength is quite poor. And that's where like the AxIT's kind of handy to do the isolated knee extension strength. So yeah, actually, look, you can functionally, you perform quite well. When we isolate your knee strength, it's like, there's bits to improve here. And if we can get this up 20-30%, it's like your ability to get off the floor with your grandkids or climb, go hiking or get up the stairs to the airplane is like, massive improvement. And the visual feedback that we get from the AxIT, that people really appreciate that as well. As like, it's also talking numbers and stuff, but like, if you see I was here and I'm now here, it's like, it's a really, from like a from a buy-in side to keep people coming to make sure that they still do this for the rest of their life because it's so important. It's a massive bonus.
Yeah. I think you mentioned, didn't you, about some barriers, especially with the older population, and sort of, I guess, how an AxIT system or just sort of assessment technology or tools that you use generally, I guess that way to motivate, engage this particular population is more so than ever, isn't it, really, with the guys telling us a lot of factors that can, like I say, they can turn up and not have a certainly good day, but for them to be encouraged constantly with visuals, being able to see how they are, or even if they didn't feel great, but then being able to see a test and actually know you're performing well, you're good, you're on track, and it's continually motivating, isn't it? And I guess that's really good feedback for these particular patients.
Yeah, look, I think the like always the dynamometry stuff, it's great to use it in your ACLs and great to use it with your kind of returning to sport criteria and things like that, because the evidence, there's mountains of evidence for that there as well. I think certainly in the older population, like in the similar way that like protein is like, needs to be pushed more in the older population now. It's not just like, oh, I go to the gym and you take protein. It's like, well, no, you're getting over 60 now and we don't want to lose the muscle mass you have. Like you need to be up in your protein. The same way the dynamometry now comes in the same, it's like, okay, we're not returning to sport, but we're just like, okay, your strength is not where it needs to be.
Yeah.
And, your functional level, you're at risk of, if it does hit the fan, then you're going to hospital. It's like, you're going to struggle to get over it. And then when you come out, you're going to be in a worse situation. So like not trying to put fear into them that way, but if it happens to come up in conversation about why we're doing these things, you can allude to these things.
Yeah, definitely. You mentioned as well about sort of, pushing these particular patients as well. That's really important, isn't it? And, objectivity tools in general, let's say the AxIT system and how that works. I guess it's just supporting safe but progressive training as well, which, confidently being able to push limits for these patients, which is just so important, isn't it? Because if you're not doing that, then so you're not, all the other factors are going to come into play, aren't they? And it's more of that guide and exercise progression.
Yeah, they're generally underloaded as a population anyway. So like if you can, even if you, like the last couple of months, we've noticed like when we've done these and then we've got into like, we've been able to like do the session and then get somebody back in two days later to start the program. And they've said like, oh yeah, I was like doing a max effort on that knee extension and my quads were like really wobbly, the day after, even just doing 3 reps, 5 seconds of max effort. It's like, well, okay, yeah, so we know you've clearly not done a lot of max effort stuff in a while. Okay, that's fine. We've got a good standard where we're going to come from. When we retest it again in the future, that won't happen. Plus, you'll be a lot stronger if consistency is there. But yeah, it's really useful to get the buy-in, and there's an element of trust, I think, that it builds. And that like can't just like, again, Irish mommies are just great. It's like they'll tell you to your face like you're full of it, like so, but yeah, you've got to be able to say, look, this is the score, this is where we are, and yeah, so it's really quite like helpful to get them to realize, okay, I can actually push harder.
Yeah,
there's more in the tank.
Yeah, excellent. We've just had a live question come through about what is the makeup of the group monitoring exercise sessions, physio/physical trainers/nutritionists. Is that maybe to do with the program that you are involved with? Is there any other, I guess, multidisciplinary
people involved? Yeah, so I will lead it. I'll program and I'll deliver the program. There's a couple of coaches who, if I'm away or something, the coaches will drop in and be able to cover, which they're generally strength and conditioning qualified. And then we've done kind of trainings with them, and we have regular kind of catch-ups about who the clients are. And a lot of the coaches, because of the type of gym that it is, it's a very kind of good community in this gym. So like a lot of the regular gym memberships will know the masters clients, and it's not very separate. They're all intermingled. So the coaches will know a lot of the masters clients as well anyway. So they're quite confident, kind of with those coaches coming in and delivering when they need to. And from the nutrition side, yeah, there's a coach who heads up the nutrition for all of the members of the gym. So that's anybody who's in regular gym membership, personal training, or in the master's program has potential access to that as well. And now that could be just like a one-off chat and then catch up in like 12 weeks. And like, and then if we need to do something, but we monitor them from that's where the in-body scan then comes in nice as well, is that because we're trying to do that a bit more regularly every 3 months now. And that if we start to see like, okay, yeah, muscle mass is coming up, but body fat's creeping up a bit as well. And like, we're starting to notice it's that's affecting their other health markers, maybe their cholesterol's up, maybe their blood pressure's a little bit up. That we can then kind of cut that early rather than having to contact GP and go through all those things, that we can actually start addressing diet as soon as possible from there. So, and then that might need more, if they need more one-to-one kind of nutritional coaching over a space of like 12 weeks, then Tara would do that.
Oh, that's great. I think off the back of that, we did have a question as well about any ideas of management of people in care and residential homes. So I guess, do you have any experience, in multidisciplinary teams in the care of older patients? I guess maybe in the community care or OTs, for example. Do you have to get involved with any of that outside of sort of the program, or?
Outside of the clinic at the moment, no. The kind of nursing home and community care stuff, it would have been a while since I've been involved with that. Especially in Ireland. Like an idea side of things is, I'd certainly be looking at like, especially kind of knowing principles of like strength training and like, okay, like knowing what am I trying to achieve? And this like 3 times 10 is not bad. Like it's not a bad place to start at all. But like if I'm trying to get somebody stronger, again, we look at the definition of physical strength, and that the higher the force that they can produce, i.e. the heavier weight they can move, the stronger they are, then we need to be like at least varying, okay, sometimes we're going to go up, try and push them a bit to fatigue, maybe 10s and 12s and 15s. But at some point then that weight's got to go up and we've got to start dropping that. And okay, I'm moving that for 8. I'll try next time we'll go heavier, but we'll only do 6. And next time I'll drop it and we'll only do 5. So the weight's getting heavier, but maybe the repetitions are getting less. In terms of like access to equipment, I imagine it's really hard. Like I'm very, very lucky in the fact that I'm like, where I'm set up, and that's why I set up where I did to be able to do this. But if you've got the potential there in the nursing home to have some small elements of like the adjustable kettlebell, adjustable dumbbells and things, and just that it's, I mean, even bands, they get a bit of a bad rap, but bands are okay to like, if I've got a 5 kilo kettlebell, it's like, okay, that's not heavy enough. But if I sling 2 black bands across that as well, it's like suddenly it's like, wow, this is fairly hard. It's like, you've got to work with what you've got there. But again, the principle of the strength training is like, okay, that peak force, that force has to get higher at some point. Just like from a community care or from a nursing home side of things, even if you're operating in that environment, the principles don't change.
Yeah. Okay, great. No, that's useful. We had a question about sort of the top 3 to 5 assessments you would choose from for someone 60 plus to help convince them to start strength training. You went through a couple there with the AxIT system as well. Would you ever vary from sort of what you do with each one, or tend to stick to a quite a number of exercises or assessments?
I suppose like from the top assessments, so I suppose like the grip strength is a big one. It's so easy. It's so quick and easy. And then you can like tell them, actually, grip strength is very good. You don't have to worry about that too much. And then you can move on to then looking at things like a 30 seconds sit to stand, or then having a look at like gait speed's a little bit, it's probably hard to set up and be consistent with. But definitely, like obviously the AxIT for the peak quad strength would be the thing. If you haven't got room for force plates and then things like that, then definitely dynamometer for knee strength. Everyone's got a bed, in their physio clinic, and they can attach that to the bed. And you can do that from there. And like definitely like the floor, like seeing them getting down, even just getting down to like a lunge or a kneel. Like, can you kneel by the bed? Can you get onto your hands and knees? Can you get on the floor? Like that as a test is it's about as strong an indicator that someone needs to get fitter and stronger in their muscles as anything. Very maybe, if you took Maria, she can do like full burpee and everything like that at the moment. Like, she flies down and up. But like, you take somebody who has never done strength training and start the program, it's like they get on the floor and it looks awkward and uncomfortable. So if I was starting over, I'd probably look at definitely grip strength, some sort of quads measure, which like the dynamometry would be handy for that, and on and off the floor would be like definitely the first three that I would think I would do as like my assessment.
Yeah, excellent. Just the last couple then. So do you think older people get too easily stereotyped as having limited mobility?
Yeah, I do. Yeah, shock. No, I think like definitely it's definitely a lot better in Ireland in the last even I started the program now 6 years ago, and definitely in the last 2 or 3 years it's become much more kind of normal, to say I'm going to the gym, lifting weights in the older population. Now I could just have like a big kind of bias because of the types of people I'm seeing on a day-to-day basis anyway. And the GPs and the consultants are very good at referring those patients who are probably going to do well in more. They're referring them earlier, so it's not like they're waiting for something to happen and then that being the trigger. But definitely from it's like the old you're a bit old for that now. We recently had there's been people who've never climbed a mountain, and like Carntool is like the highest mountain in Ireland, I think. They've kind of climbed that, which is it's higher than Snowdon in Wales, and I know that. And I've climbed Snowdon, so it's it's harder than Snowdon as well. It's a bit of an animal, the Carntool. And then we've had like Dan, who's like 60, how old is Dan? 66, 65, and he just did base camp of Everest. So is like this idea that you've got to envisage of what what would you want to be able to do at 60, or what would you want to be able to do at 65? I want to be able to do cartwheels. So it's like okay, if you can't quite do a cartwheel, it's not the end of the world, but at least the attempt of you trying to keep that ability is so important for being able to get on up and down the stairs and on and off the floor. But yeah, the idea that you've got to, and this is where a lot of programs around age appropriate. Again, there was about 4 or 5 ladies who came in one time, and they'd been to a kind of older adults sort of exercise program, and they came into me and they was like, just checking what this is, because we were sat in a chair doing lifting the knees and pumping their ankles and stuff, and it's and now these ladies now, they're lifting 50 plus kilos and they're squatting 30 kilos and they're back and it's, if they didn't take the idea as I'm not happy with this, and they just accepted it, they'd still be doing chair exercises, and I'm not getting any stronger. I'm probably worse for it. And it's not as a result of anybody who's taking the program. It's not their fault. It's just, that's what's been passed down a lot of the time from a lot of the healthcare programs.
Definitely, and I think that's really important. Last question then. So what standards do you use to compare older adult measurements?
So the grip strength, I think there's the German study in this webinar presentation that is really, really good for the grip strength. It's measured in kilos, and then they stratify it for height, and they stratify for their age and sex as well. So you get quite a good accurate measurement of what their grip strengths should be, and what, if they're below the threshold, are they at risk. So that's a really good one. For standards in older population for like quad strength, again, I didn't include it here, but if they want to drop me a message, I can send it on as a quad strength measure. But also, it's really handy that the AxIT just has that as standard on the kit, in that it compares it to percentage of your body weight, whereas like I think 60% of your body weight in a knee extension is a kind of good baseline to really be.
Important for reporting as well then, isn't it? Like I say, just to have that from the write-off. So yeah, great. Well, that's all the questions that we'll cover today. And yeah, we've gone through any that came through live. So thank you everyone for joining us, and thank you, Sam, for presenting. Really, really interesting. So yeah, great to see. So for Sam, obviously he's on Instagram, and you definitely share some really valuable resources on there. So definitely follow at Go Beyond Physio, and yeah, to search Sam Jahan with it. I
wasn't a dig at you. I swear I wasn't a dig. It's just like I was like, everyone spells it wrong. Everybody spells it wrong. So yeah, it's like
I thought I checked that, and then actually double bluffed, and I was just like, oh no, it's not, it's that. Yeah. So anyway. So Sam with an R, definitely check it out. She's great to see, like I say, you working in this field, definitely. So as well as that, we will follow up with the recording as well as a survey. So if you do have any feedback or any future topics to cover, then we would like to hear that as well. And if you have any questions for us at PhysiQuip, then please do reach out as well. So thanks again, Sam, and thanks so much for your time. And yes, enjoy the rest of your day.
I do. Ta-da. Thank you. It's been great.
Bye.